Good evening, everyone. Thank you for joining us tonight for our phalangeal fracture webinar. I'm going to go ahead and get started here. So I'm Chelsea Bowe. I'm your moderator for the evening, joined by our wonderful faculty. Tonight, we'll hear from Dr. Kim Mezera from the Texas Hand and Arm Center and Dr. Kevin Malone from Case Western. Thank you to both Dr. Mezera and Dr. Malone for joining us and sharing your experience and expertise. Our disclosures, which have no bearing on our discussion tonight. Tonight's webinar does qualify for 1 CME credit. To claim credit, please look for the emailed link in 24 hours to complete an evaluation of our presentation, claim credit, and access your certificate. This is the content validation for AO North America. For this webinar, your camera is off, microphone is muted. Please send questions or issues via the Q&A. I'll screen and present your questions to the faculty speakers following presentations. Please don't use the chat feature. Our webinar tonight will review phalangeal fractures, the unique challenges that these fractures represent, specifically with regards to the balance between sufficient rigidity to promote bony healing and the need for early range of motion with limited soft tissue to accommodate hardware. We'll identify unique fracture patterns suited to certain fixation types, recognize the relative risks and benefits of several different fixation methods. We'll discuss how to anticipate and prevent complications and then treat them when they inevitably arise. Finally, we'll review some representative case examples to emphasize the need for familiarity with multiple treatment options to maximize outcomes for your patients. The burden of these phalangeal fractures is not insignificant. They represent 18% of all upper extremity fractures. They represent the most common hand fractures and account for a loss of $2 billion of productivity annually. It's in no small part due to the fact that the complication rates in the literature are as high as 50%. Our objectives for today: by the end of the session, you should be able to discuss phalangeal fracture patterns, surgical treatments, and which patterns are suited to which treatment. You should be able to compare relative risks and benefits of surgical treatments, as well as anticipate, educate, and treat patient complications related to these fractures. By way of an agenda, I'll stop talking shortly here, and Dr. Mezera will review for us the tried and true strategies of phalangeal fracture fixation. I'll then cover intramedullary fixation, and Dr. Malone will explain how to fix it when it doesn't work like it should. We'll then do a few cases and adjourn, hopefully right on time. Few upcoming events to mention, including fellow and resident course in Cincinnati in May, where actually all three of us tonight will be joining as faculty. Hand and wrist fracture management course in Chicago in November of this year. More to come on that. Scan the QR code for a full list of upcoming events and how to register. Several upcoming online events, a few other webinars, including a complex distal radius discussion in May, as a webinar on the dreaded scaphoid non-union in August. Please look out for the 2025 online series, Monthly Topics, headlined by a sage, sharing their wisdom on topics we all face regularly. I learned something new at all of those. Great resource. And finally, we have one AO coming up in April in Henderson, Nevada. Scan the code for all the info. This year's focus is AI, potential reality, and impact. And with that, I'll pass it off to Dr. Mezera.
All right, thank you, Dr. Bowe. I appreciate that. Let me share my screen here and see what we can. All right. So let me go back here. So my task this evening is to talk about what I call the timeless classics, the plating and pinning of phalangeal fractures. So a lot of basics that we'll go over and review. Just some objectives, kind of what we had just mentioned, but we want to understand kind of what the principles are here in these phalangeal fractures, what our goals are, also what techniques we have for fixation, and then how to decide what fracture has the need for what technique. There are some challenges in phalangeal fractures, and I think the biggest one is soft tissues. Our fingers are so amazing with all the physics, with the moment arms and the pulleys and joint motion and arc of motion. It's great, but it does present a challenge when you're trying to restore that. And the soft tissues do play a significant role in our outcomes. And they're there. We would like to try to avoid them, but we can't. So that's just part of the deal. When you have a phalanx fracture, it's actually more than just a bone. So we know the arc of motion is very wide when you think about making a full composite fist and what has to happen for all that complex anatomy to work together. So when one part of the system goes down, it creates a domino effect, which then can be challenging to fix on the back end. There's no tolerance, unfortunately, or little tolerance for any angulation or malrotation. So that has to be also be very diligent and mindful about that when you're fixing these fractures. Speaking about kind of scar tissue, and it's kind of a race in these fractures between the biomechanics and fixing the bone versus the healing biology. It's a neck and neck race, and often we seem like we're working at different ends of the spectrum on this, and it can be very frustrating. But when you think about, you're trying to fix a fracture as shown here, in this kind of diagrammatic sketch, but the scar tissue is in the healing callus and all that is right next to our extensor tendons, our flexor tendon sheath, our pulleys, our capsule, collateral ligaments. It's all in the mix. And so in trying to be helpful, sometimes the iatrogenic scar from our surgery is actually kind of puts us behind the 8 ball even further. And so we'll kind of talk about some strategies with that. And again, just to mention, this seems very basic, but it can be a little humbling sometimes when you are trying to fix these phalanx fractures, especially if they're unstable. The malrotation, loss of cascade, scissoring, it can really be aggravating. And so just have to be aware of it. And always examine. Teach our residents always examine in both flexion and extension, because it's possible that something looks good in extension, but when you flex, you're like, oh no, it's scissoring. It's actually not good. So be very diligent about that as well. And this is just kind of a representative case. It might be a little dramatic, but this patient obviously has some phalanx issues. And, we have soft tissue, we have malrotation, we have obviously some joint involvement. And so this is kind of the challenge of the challenge. And this is kind of x-ray just to kind of look at what we've got. So, we have a middle phalanx that has a transverse fracture. We have a periarticular fracture, of the ring finger and of the small finger. And it's just challenging. And these fractures don't all need the same thing. So as the surgeon, you have to be prepared to have many little tricks up your sleeve and having your toolbox quite a few options to deal with all these different fractures. Just looking, this is obviously kind of the finished product, but we have a combination of plates, we have wires, we have lag screws, we have K-wires. There's a lot of stuff that was thrown in this, but that's kind of what it takes. And each fracture kind of demands what it needs and what you can use. And we'll go over some of that in our principles. So we want to obtain reduction. So that's the first thing. Then we want to maintain reduction. And that leads to our, fixation choices. What we want to have the most stable fixation we can in order that we can mobilize early and then rehab the patient. And this is a great plan, but it doesn't always work like that. And sometimes you have to kind of change your plan in midstream based on what you find or how the bone reacts to what you've chosen and how stable your fixation is. There are also confounding factors that, in addition to the biology of the healing process, that kind of get thrown in our path. Patient factors include age and comorbidities. Patients diabetic, if they have some soft tissue issue, if they have lupus or scleroderma, rheumatoid arthritis. There can be a lot of things that are thrown in there, diabetes, that can kind of cause us some postoperative healing issues and make it even a more difficult situation. A patient's vocation, also important. Are they a desk, kind of computer office-based practice career, or are they manual laborers who need to hold tools and do that? So that can be life-changing for them depending on what they do. And then the patient's motivation. I would say that some of the toughest rehab is in phalanx fractures. For the patient, meaning you have to, it's a marathon. And I always try to coach them at the beginning saying, this is going to be a 6 to 9 month thing. You're just set your mind at that. We're going to have to work very hard. You're going to get very tired of seeing a therapist. You're going to get very tired of doing your home exercises, but you have to keep going. And so trying to motivate the patient to be able to see it through to the end can be definitely a role that we should play. The fracture itself, I mean, the location, the proximity to the joint, the pattern, if is it oblique, is it transverse, help dictate what we're going to do, and also help predict the stability of the fracture and what we need to do. The ease of reduction, I mean, it is nice to close reduce things. I mean, we always like to avoid incisions if we can, but that doesn't always work. Sometimes you do have to open it just to reduce it. And then the length of splinting, you know, if you are unable to do the maybe plan A fixation that you wanted to, then, and you end up doing K-wires, you just can't, you have to hold them still just a little bit longer. I mean, that plays into your kind of your recovery. Just to briefly, I'm not going to dwell on this, but just looking as you plan your surgical approaches, if you have to open these fractures, it's nice, I like to do at least, is not to make my skin incision and my tendon or move my tendon over it, kind of make it all in line, like stack it. I like to kind of offset it. And I like to try to, as much as I can, be very diligent about creating a periosteal flap. I mean, it's easy in young people because they have nice thick periosteums. In an elderly patient, sometimes there isn't much periosteum, but if you can, as you go in, because it's once you expose the bone, if you haven't done it, it's probably too late. But as you go in, try to create a periosteal flap that's offset from your skin incision and from your tendon sheath, and that may help to diminish some of those adhesions. But there are a lot of things to worry about. I mean, we look at the tendon anatomy, the lateral bands, our sagittal hood, our flexor sheath, pulleys. I mean, it's amazing that we do as good as we do, because it's a very complex system, and try to avoid, going kind of right through the lateral bands, and try to mobilize if you can to try to stay out of that area. So I thought we'd just go through a few cases just to kind of illustrate some of the techniques. I'll start with the distal phalanx. This is a case that I had not too long ago. And I thought, oh, this is great. I'm going to plan to do some little screws. These little screws they'll be so fancy. It'll look great. I'll do maybe a 1.5 or a 1.0. I'll put that little piece of bone back, restore the joint, put some screws in. And I see that, kind of down here, down by the PIP joint, there's a little fleck of bone. Maybe, what is that? Is that just the oversight, or is that something? Could that be possibly the end of a tendon that has retracted? And so I have a tendon and a bone injury, etc. So I'm kind of planning as I go in. And indeed, that was the end of the tendon. It had avulsed, and it was sitting back here. But this piece that I thought was going to be one piece that I could so nicely fix was actually three pieces, as I found only when I was in there. So my plan A kind of fell by the wayside pretty quickly. So I had to go to plan B, and plan B ended up being K-wires. Not my favorite for this, but I was able to do the job. I was able to restore congruity of the joint. I was able to put the piece back, restore the articular surface, put the tendon back to bone. I don't know if you can tell, this is kind of a light because these are just the post-op. I had to repair the tendon over a button, the old-fashioned button on the fingernail, just because I didn't have enough stability here, at the base to be able to put the tendon back down. I had too much comminution there. So I had to bail on my plan A, plan B, and I had to go, my button was kind of a plan C. But the patient did well, and it turned out fine. But again, just to show you that your K-wires can be a nice bailout. They can save you. This is a middle phalanx fracture, and this one is a more transverse, kind of almost a mid-shaft. And those lend themselves very nicely to K-wires. I think if you are in a place where maybe you don't have intramedullary fixation, which is also, and Dr. Bowe will talk about that, but that's nice if you can access that, and if your surgery center has that or your hospital has that. But if not, this kind of lends itself nicely to K-wires in that the transverse nature is a little bit more stable once reduced, and the K-wires can control that pretty well, especially in a cross-pin fashion. This could also be plated, if you could also choose that. But the challenge, again, is our soft tissue. So I tend to, if I can avoid doing a plate on a fracture that's a simple pattern that's stable with K-wires, I kind of choose that. I think the patient maybe does better in the end. But it's not to say that you couldn't do this. And this patient did well and had a good range of motion with the K-wires. I would typically leave the K-wires in 3 to 4 weeks, depending. That's just me. Some people like to take them out earlier, but I like to leave it in. The patients that are a little older, I might leave it 4 weeks, just depending on how robust their healing is. And I tend to go a little bit more by clinical tenderness than I do almost by X-ray appearance, because I think in the phalanx, I think the callus formation and the fracture healing radiographically kind of lags a little bit behind what it really is. So I tend to use clinical exam a little bit more to make me feel better about taking the K-wire out. Again, deforming forces, this fracture kind of just, back to our point of soft tissue and the systems and the pulleys, the central slip, the intrinsics, the FDS attachments, all those things are deforming forces for us. And so we have to kind of think through the anatomy to understand how to reduce the fracture and what we're trying to correct or reverse to get the stability we need. So proximal phalanx, these are just 3 different proximal phalanx fractures, and they're all a little different. I mean, they are similar, but they're not. And I think we go through, each of these and talk about how the fracture pattern can help you understand what you should do with the fixation and what fixation you should choose. Let's start with this one. So this one is kind of, obviously, it's a little bit comminuted, a spiral oblique. It does tend to go very close to our articular surface and to the condyle, distally at the PIP joint. And proximally also, there's a minimally displaced fracture at the base. So the fracture extends basically across the whole entire proximal phalanx. And we know that plate fixation is good, but we would like to have the plate a little bit on both proximal and distal sides of the fracture, and to provide the stability we need. And it's nice to avoid, if you can, putting K-wires or screws through the collateral ligaments in the, kind of right around the PIP joint or even on the DIP joint. But we know that if you take a screw and put a screw through that collateral ligament through a plate and then tense it down, it does cause you problems with tightness and contracture of that collateral ligament, which will come to haunt you about 2 months down the road when you're trying to mobilize that joint and it's really, really stiff. So it's best avoided. If you can preserve your collateral ligaments and not put hardware in that area, that will give you a better result. So, this is a spiral oblique. It has obviously the directions are different. So plating might be a little challenging. K-wires aren't going to help you here because they can't control this fracture. There's too many planes of displacement. So this might be one that lag screws would be really appropriate for. And you can see these lag screws, it almost looks like we're kind of like the surgeon was a little bit crazy, like they all go in all different ways, but that's because you follow the fracture, right? And so that's actually a good thing to see because we know this fracture is a spiral, and we like those lag screws as best we can to be at 90-degree to the fracture plane. So this worked very well, and the patient ended up doing very well with range of motion. Another one of our proximal phalanx fractures. This one is a little different pattern, still a spiral oblique, a little shorter spiral, but our articular surface is spared, and our distal condyles are spared, and proximally we have a pretty good piece at the base of our proximal phalanx. So this fracture is more amenable to plating for stabilization. It might be a little short for the lag screws. We want those short obliques don't do very well with lag screws. They do better with the plate. So this one, just because of the short obliquity and the fact that we do have some good bone on either side, kind of lends itself well to a plating. And the lag screws still are, come in handy. You can see there's a couple lag screws here. They still are helpful at the beginning when you're trying to get your fracture stabilized for, placement of the plate. So that technique used together is very helpful. And again, patient did well with range of motion. So looking at another pattern, this one is a little different pattern, a little bit more of a proximal base with some, I don't know if you can appreciate it on the lateral here, but this is, the base here, and then we obviously have an extended phalanx at the fracture site. So we have a hyperextension at the fracture site and some rotation. And looking kind of, in this, if you have to open these, and again, sometimes we do, to get the reduction, I try to make as small incision as I can. I'm not a big fan of doing it's nice to see everything, but it's just more scar tissue. So if you can accomplish your goals, try to keep the incision small just to see what you need to see, but still be able to properly reduce your fracture. And a T-plate works very nicely for these in order to stabilize that short proximal base and reduce it back to the shaft. And again, patience does well. Another kind of example of this with, again, the plate going a little bit farther. You have to be careful not to put your screws in the fracture site. That, as obvious as that sounds, there are times when it seems like fate is against you and you're like, that's the only way the angle wants to go. But just try to be cognizant of that and avoid. This is another patient that I had not too long ago, but this was a similar type of base of the proximal phalanx. But as I, on closer inspection, looked at these x-rays, I'm seeing another little density that appears here in the base. And as it turns out, that was an articular fragment that was about a third of the joint that was impacted probably a good 3 to 4 millimeters into the base of the phalanx. So a big chunk of her articular surface was there. And when I got in there to reduce, I realized that I actually had a fragment. This condyle was a free fragment. This condyle was a free fragment. The articular fragment was obviously a free fragment. And I had some smaller little, I call them kind of dust particles that seem very too small for fixation, but yet necessary for the stability. So this was a challenge. So doing a T-plate, which initially I had thought would be a good idea and had that prepared, ended up that it just didn't quite fit the fracture fragments. I couldn't really reach what I wanted to reach. So I ended up bailing on that idea and ended up doing K-wires, which again, it's open. We created scar. Now I'm putting K-wires. I feel like I can't move it that soon. So it's not the optimal thing, and it's not what I had as my plan A. But I think it's a good example of sometimes you just do what you can do and try to get the fracture, get your joint stable, reduce that articular surface, and then move as soon as you can. I know we kind of talk about, like K-wires are not a good thing, but I don't want you to feel that way. They actually are a good thing and they can be a good bailout. We always love it if we can get better fixation, but sometimes you can't. And this patient did very well, actually, in her joint. I mean, I thought the most important thing here was obviously we wanted her joint to be reduced because that's what's going to cause her trouble down the road. So just kind of looking over just at some of these examples, some of the take-home points I'd like to just review. The fracture pattern, look really closely, get some additional views if you must, if you can't really tell like what your fracture pattern is, because it will dictate what you can do and what you can't do. I'm not a big fan of CT scans in the phalanx, but if you really can't tell and you're really worried and you don't know how to prepare, I mean, it's okay to do that. But sometimes just the different views can help you greatly to understand what you have. And then be really in your toolbox, have more than one fixation method. I mean, we all learn on K-wires. That's a thing that residents, we learn that way. And that's great because they're good at the beginning and they're good at the end when you have nothing else. But be comfortable with doing lag screws, be comfortable with plating, be comfortable with the different shapes of plates that you can use. T-plates, straight plates, curved plates. I mean, just be comfortable with what's out there and kind of step outside your comfort zone sometimes and try some of those things so that you can be prepared, and anything that comes at you, you'll be ready for. Always have a plan A, B, C, and D. Be prepared. And when you're posting your case, be prepared, to post for your small frag stuff, your mini frags, your K-wires, if you want anchors, if you want, just have it all there, because it's good to be prepared, but you don't want to be left kind of sitting there going, I wish I had, the plates, but I didn't post for them, so I don't have them, and they have to be brought in. So just be aware of that. Be patient. These are very humbling fractures sometimes, and they're tedious. And I've been at this for many, many years, and I still say they're humbling. And so just be patient. Sometimes less is more. If you're having problems and things are just falling apart before your eyes, take a step back, and maybe K-wires are going to be the thing, or even an X-fix. So try not to be too sassy, and try to be too smart. It can kind of come back on you. If you can, again, I'm sure we all talk about this, try to move as fast as you can. As long as you have stable fixation, and the longer we wait, the harder it gets. And then check your cascade. So anyway, thank you.
Thank you so much, Dr. Mezera. That was great. One of my former partners used to say, if you hate somebody, send them all your phalanx fractures.
That's true. You could do that.
They are humbling.
They are humbling.
Yeah.
They're fun and they're challenging, but they're humbling.
They are. It's kind of like one of the really hard distal radius fractures. You love them, but you can only do so many.
Yeah.
Like you take a break.
You got to take a break. That's right.
You gotta take a break. All right. So we're going to change course here just a little bit. So Dr. Mezera was kind enough to cover for us the basics of phalangeal fractures. And we're going to talk now for a little bit about something very specific. So putting the hardware in the bone, intramedullary fixation. So we all know and are familiar with AO principles of anatomic reduction, stable fixation, preservation of blood supply, and early mobilization. Nowhere is that last point more key than in the digit, where hardware can easily impede mobility and lead to poor outcomes. Even in the case of K-wires, which maximally respect the fracture hematoma, preserve the blood supply to fragments, and can afford sufficiently stable fixation, there's an extremely high incidence of violation of soft tissue structures, specifically around the MP joint, which can limit mobility and the mobility substantially following phalangeal fixation. You can make the same argument around the PIP joint, which makes it really appealing to take advantage of that intramedullary space for the bony fixation. Intramedullary fixation is hardly new. This is a little bit of a history jump here, but the Aztecs in the 1700s treated non-unions with resinous wood sticks inserted in the medullary canal. There obviously was a flurry of advancement of this technology in the early 20th century, and we're now all familiar with intramedullary fixation throughout the body as a standard of modern orthopedic care. It's not new in the hand either. I don't make a formal pronouncement that this is the first appearance in the literature, but the Rush brothers described the use of a longitudinal pin to fixate 2 cases of metacarpal fractures. And with this image from their 1949 article, they indicated the role for intramedullary fixation of metacarpal fractures. It's been adapted to phalangeal fractures with the use of intramedullary pinning. This was reported in the literature in the 80s and early 90s. And then in 1997, Dr. Weiss described the use of a Herbert screw for fixation of middle third phalangeal non-unions, noting the immediate stability afforded by this technique. Patients were appropriate for a soft dressing and quite early mobilization. He reported a high success in achieving union in that setting. Of course, we all know Del Pinal published his series of 21 phalangeal fractures treated with intramedullary headless compression screws in 2015, which really has sparked this robust interest and widespread adoption of this technique. He advocated for the expeditious, soft tissue-friendly treatment with this load-sharing intramedullary device that allows for early range of motion. His early results demonstrated a promising alternative to plates, screws, and K-wires for these fractures that are quite common and can be fraught with complications. As Dr. Mezera told you, there's not a lot of place to put that hardware. It can be hard to find the right place to put it. And even by opening at that level, you're introducing scar tissue. So this really avoids all of those potential complications. Several studies have been undertaken evaluating the relative tensile strength of intramedullary screws, predominantly focusing on the metacarpals. One such study shown here demonstrated superior strength of the dorsal plating construct, but noted the advantage of intramedullary headless compression screws relative to those intramedullary pins or intramedullary K-wires, when you're looking specifically at a transverse fracture pattern or osteotomy. Evaluating bone loss or length unstable patterns without circumferential cortical contact, dorsal plating remained far superior to all other constructs, but the intramedullary screw approached some plating in load to failure. It's really important to note when you look at these biomechanical studies, this 4-point bending doesn't represent the physiologic load and bending moment during MP flexion. It's really quite a bit smaller than what we're looking at in these constructs. So the actual bending moment force is reported about 0.35 Newton meters, which is orders of magnitude less than the testing of all of these constructs, specifically the testing to failure. As intramedullary fixation of the metacarpals has gained popularity, further clarity has come from the consistent outcomes in repeated biomechanical studies. Dorsal plating represents the strongest construct, followed by intramedullary screws of appropriate size, followed by K-wire fixation. But all constructs far exceed the strength for physiologic loading for early motion. In reviewing the data specific to the proximal phalanx, which is of course the most common phalangeal fracture, similar patterns appear. There's things we know, as Dr. Mezera said, that perpendicular fixation, those perpendicular lag screws, is quite strong and is the strongest for oblique fracture patterns. For transverse fracture patterns, crossed wires demonstrated best resistance overall, but intramedullary fixation with K-wires achieved similar lateral bending and torsional resistance. And remember, this is K-wires, not screws. When you use that similar non-physiologic loading mechanism with that 4-point bending, as you saw in the metacarpal testing, dorsal and lateral plating are still superior constructs for transverse midshaft osteotomies in terms of ultimate strength. They clearly show that it's the best to resist deforming forces, but we don't fix fractures based on the strongest overall construct. We need to balance the principles. The goal is sufficiently stable fixation to allow for motion, because motion is the #1 problem with these fractures, and we need to work on getting to that early range of motion. Keeping in mind the more physiologic state, this condition was tested with repeated flexion extension cycling in the study from 2021. In that testing, they couldn't find a difference between a plate construct and an intramedullary screw construct. This suggests, as in metacarpal fractures, that headless compression screws are sufficiently rigid to resist deforming forces at the fracture site for immediate range of motion. But we need to address the elephant in the room, the access to the intramedullary canal. We're fixing a bent bone with a straight device through the IM canal, and as a result, we have to violate a joint surface somewhere. There are several ways to accomplish this. We can go retrograde through the distal articular surface, anterograde with dorsal subluxation of the proximal articulation, or transarticular, creating defects on both sides of the articulation. The size of the articular defect, of course, varies with the size of the screw. It's proportionally more of the distal articular surface than the proximal articular surface, given the difference in size of the overall joints. It can represent as much as 24% of the articular surface of the P1 head, compared to around 9% of the P1 base. These findings have been validated with a CT-based study, which noted similar proportion of the joint impacted with anterograde and retrograde screw placement, and similar anticipated size of the kind of kissing lesion created by the transarticular placement through, in this case, the PIP joint. The articular defect does have an impact on joint contact pressures. However, in the case of the P1 base, this contact is less relevant when the joint is flexed, which is really a position of function. In fact, the metacarpal head doesn't engage with the entry site in the dorsal 1/3 of the P1 base for 90 to 95% of the 120-degree arc of motion at this joint. So the clinical relevance of this articular defect is really largely unknown. And we still need long-term data to understand the contribution to further arthritic change. So indications for IM screws include transverse and short oblique diaphyseal fractures, situations where there's significant soft tissue concerns and you don't want to place any hardware outside the bone. If in a situation where you have patient compliance concerns, where you want to be able to let a patient go and let them move right away and trust your implant, and then in replants with appropriate fracture patterns. In the proximal metaphyseal fractures, intramedullary screws can be used, but with consideration for the pattern and potentially using a double screw construct. IM screws can also be considered in comminuted or length unstable patterns, but in those cases, they're best served by a non-compressive screw. So for example, a non-variable pitch would be a simple way to avoid the compression conveyed by a variable pitch screw. Contraindications include significant articular involvement and open physes. That dual screw construct, or the strutting technique described by Del Pinal, is essentially using an architectural principle to support the fracture in multiple planes, preventing collapse when there's comminution or lack of bony support. So the intra-articular technique begins with pre-op planning, just like every surgery we do. So the width of the intramedullary canal should be measured at its narrowest point on the lateral radiograph to approximate the screw size. You then intraoperatively perform your reduction and actually take that screw that you're proposing and overlay it over the phalanx to get an understanding that it's going to pass through that canal easily. Often our hand radiographs aren't calibrated for precise measurements, so your pre-op measurement is an idea and you need to check it intraoperatively. In this anterograde intra-articular technique, an incision is made over the MP, splitting the extensor. The start point is directly visualized and confirmed radiographically, obviously in multiple views. You then pass the wire holding the reduction, similar to if you were reducing a femur. And then you decide whether or not you need to drill. So drilling through the isthmus is indicated if the path is anticipated to be tight, and it's really especially important in young bone. The digits are then typically held flexed in a fist as the screw is passed to control rotation. The incision is closed and motion is started at the surgeon discretion, but generally within 3 to 5 days. The transarticular technique is also diagrammed here. Similar steps, obviously not opening the MP joint, opening proximal. The retrograde technique is largely similar in terms of the pre-op planning. Again, the importance of pre-op planning. And then confirmation of your screw size intraoperatively. The incision is made over the PIP joint with the PIP inflection to clear the P2 base for direct access to the head of P1. The extensor is carefully split, avoiding damage to the central slip insertion. The starting point at the central dorsal aspect of P1 is identified and confirmed, and you follow similar steps for drilling if needed. Really, again, also watching for that rotation as you're inserting the screw. Placing a screw wider than the canal without drilling can lead to screw incarceration, bending, or breaking the screw. I said, especially in young patients, that cortical bone is too firm to pass even self-tapping screws without drilling first to essentially ream the path. Similarly, significantly undersizing the screw will limit the contact with the bony cortex and can compromise the biomechanical properties to resist bending and torsion, and also to control that rotation. We discussed open techniques thus far, but you can actually place the screws entirely percutaneously with no open incision. This is cadaveric study demonstrated that tendon damage with an open approach and direct view of the tendon is obviously less, but with an entirely percutaneous approach, it's never greater than 50% of the tendon, which is lower than the threshold potentially for an open repair, and you would anticipate normal function with that tendon injury. The results of headless compression screws have been promising. Excellent recovery of total active motion, rare need for tenolysis relative to other techniques, and rare loss of reduction. Often when that reduction loss occurs, it's when pushing the indications of screw fixation and using it in more comminuted or basilar fractures. Delpinol's results have subsequently been validated in numerous other studies with similar very good to excellent motion recovery and limited need for secondary procedures. A systemic review from 2021 encompassing 837 patients, which included 222 P1 and 43 P2 fractures, demonstrated an average OR time of just 26 minutes, healing of the fracture radiographically at 6 weeks, sounds fast, a complication rate on the order of 3%, and excellent motion recovery. In comparing techniques, intramedullary screw demonstrated significantly shorter OR time with faster return to work relative to K-wire or plating. And another comparative study specifically looking at intramedullary screw compared to K-wires. In this study, they didn't find the same difference in OR time because K-wire can be fairly quick as well. But they did find with the intramedullary screw, there was a shorter duration of orthosis use, fewer hand therapy visits, and faster recovery of motion. And that was, again, matched for fracture patterns and similar rates of complications with both techniques. So cost is often a concern when you're comparing any treatment to K-wires, but it's worth noting that the increased implant cost may be offset by the other reductions. So reduced hand therapy, reduced surgeon visits. In this study essentially found that there were fewer hand therapy visits, fewer consultant-led outpatient visits with IM screw treatment. So this is not to say that there's no place for treatments for phalangeal fractures besides intramedullary screws, merely to emphasize the role they play in appropriately selected fracture management and the importance of including this implant in your armamentarium of options. As Dr. Mezera said, one plans A through D or F. So in conclusion, consider intramedullary fixation for transverse and short oblique fractures. In preparing plans A through F for a case, I'm increasingly using intramedullary screws as plan A for transverse fractures and those short obliques as well. Pushing indications as possible with alternative techniques based on your comfort. Intramedullary screws can be placed anterograde, retrograde, or transarticular safely with expectation of minimal impact to the joint, though of course long-term sequelae aren't fully known. When placing these screws, don't forego the preoperative planning and the intraoperative checks to prevent screw incarceration or breakage, and don't be afraid to drill. Regardless of the technique, early mobilization is key for successful outcome with all of these fractures, and it's very safe when you're using an intramedullary screw. Thank you. All right, I think next up we got Dr. Malone, who's going to talk about not
Thanks,
working.
Chelsea. Okay, so I get to bring up the caboose here and talk about all the things that no one else wants to talk about, and we're going to talk about complications. And as has been mentioned previously by Dr. Mezera and Dr. Bo, they are not infrequent or uncommon, and certainly not unfrustrating for patient and provider here. So one of the giants of hand surgery, Dr. Sterling Vanell, from 1953, gave us this quote: "Finger fractures are so frequent and result in so much disability that they cause about as much compensation expenses as do fractures of the long bones." And these are bones small enough that you can swallow. So it's puzzling and challenging for sure. Just a review of some of the things that we've talked about before. They are certainly common, much more common in men. Apparently, we put our fingers and our hands in places they don't belong more frequently than our female counterparts. Average age is certainly pretty young. High percentage of crushing injury, resulting in a high percentage of open fractures and associated soft tissue injuries, particularly flexor and extension injury. And end results of these phalanx fractures results in a pretty substantial loss of total active motion. So for fingers, 73% restoration of normal total active motion, and for thumbs, just over half of the normal active range of motion restored. So there are multiple factors influencing the outcomes, and we're going to talk about all of these a little bit in detail. Patient factors, fracture factors, and then management factors. And certainly as surgeons and also as our therapists who are part of our audience here tonight, we have the most influence on the management factors of these injuries and how they influence outcome. But looking at patient factors, we have associated diseases. Age is a part. Clearly demonstrated that patients who are of younger age do better with these type of injuries, with less than 50 years with a total active motion restoration of 70% normal, compared to greater than 50 years of age, just over half recovery of total active motion. Socioeconomic factors are going to play a role here as well. It's certainly going to impact patients' ability to tolerate surgery, to go through surgery, to be out of work, to go through therapy, whether or not they have insurance coverage for therapy. These are all things that do not exist in a vacuum. And then our patient understanding and motivation is certainly very important as well. And we do have some influence here. Education is key. Talking to these patients and setting a reasonable expectation for outcomes. In terms of fracture factors, the location, the type, degree of displacement, stability, but as has been mentioned previously, the associated soft tissue injuries. We know that there is poor outcome with articular involvement, comminution, and then more significant displacement resulting in periosteal injuries, tendon injuries, and skin loss. And in regards to tendon injury, extensor tendon injury associated with phalanx fracture has a much greater impact on recovery of active motion than flexor tendon injuries do. Recognition for our part, the management factors is recognition of the injury, appropriate interpretation of the x-ray, appropriate appreciation of the soft tissue injury, how the tissues are managed during surgery, how the fracture is reduced, the maintenance of reduction, and then how quickly we get these patients moving. And then last but not least, recognition and management of complications. These are our responsibilities as healthcare providers, both surgeons, therapists here in this group. This is an older article now from the late 1900s. Dr. Peter Stern and his group, 82 patients with 105 patients managed with a titanium mini fragment plate set with greater than 6 months of follow-up. Over half had complications, much higher incidence of complications with periarticular fractures. And one of their conclusions was that complications were unlikely due to the plate placement or the plate selection, but more likely caused by the degree and severity of the injury that ultimately required the plate fixation. So this is a summary of the types of complications you might see from management of patients with phalangeal fractures. And the bottom part here in the green box, certainly not to discount or discredit these malunions, delayed unions, plate problem, even infection and tendon rupture, but you can see how relatively uncommon these type of complications are to these on the top box with stiffness and contractures. And so we're going to focus, for a sake of time, on these top box issues here. Stiffness is a major problem. And you can see in this study of 37 patients with phalangeal fractures, the high percentage of patients that had fair to poor outcomes with regards to range of motion. 8 of these patients underwent additional procedures for stiffness. And in this study, only 1 had improvement in their range of motion. These are not benign injuries. Tendon adhesions are a problem, and Dr. Mezera talked about this in her talk. There's an intimate relationship of the tendons to the phalanx, which predisposes to excursion-limiting adhesions after fracture. There is very little compliance for additional bulk from implants or scar from surgical exposures or trauma. We all know, or we should know, the stages of fracture healing from hemorrhage to inflammation, collagen synthesis, maturation, and remodeling. And weeks 2 to 4 are the peak collagen synthesis and cross-linking, which results in a big potential for tendon to bone or tendon to implant adhesions that can develop during the stage. So if we are able to mobilize patients through weeks 2 to 4, that is great. But some of the implant choices that we may make, or some of the soft tissue injuries that may be experienced by these patients as part of the injury, may limit how much we can mobilize these patients in this critical time zone. So there are a variety of techniques here that can be incorporated to regain motion ultimately. Extensor tenolysis, which is a release of the adhesions between the extensor tendons, the lateral bands, the sagittal bands, extensor hood, and oftentimes incorporates removal of any type of extramedullary implant that was placed. Flexor tenolysis is also very similarly release of the adhesions between the tendons and the bone, between the FDP and FDS tendons, between the tendons and the pulley sheath. And then sometimes that may even require pulley reconstruction. And then once that either extensor or flexor tenolysis is done, capsulectomy may be needed as well to get the joint mobilized. It is important to recognize the potential for fibrosis of the retrocondylar space, which could limit active and passive finger flexion. And these procedures are oftentimes more accurate or more successful if done with some degree of patient awakeness, so we can evaluate active as opposed to purely passive range of motion. Tenolysis does typically result in improvement of range of motion, but not substantial range of motion improvement. About 50% improvement in range of motion, which results in about 68 degrees. Failure in further improvement of range of motion following tenolysis is oftentimes attributed to many different factors, including the degree of soft tissue injury. Infection can certainly result in much more significant scarring, and then patient cooperation with postoperative plan. Postoperative formal therapy is very high impact on outcomes. Timing is also important. We want to get to these patients early. Doing a tenolysis within 16 weeks of injury results in significantly better outcomes with regards to restoration of range of motion, as when compared to patients who have tenolysis performed greater than 16 weeks after initial injury. There are all sorts of commercially available tenolysis knives. You can buy these from a variety of different vendors, including the one listed here. they're nice, they're expensive. And if you operate at one place and one place only, it's not a bad idea to have these. As a cheap alternative, this is what I use. This is an ophthalmology crescent blade. It is a single-use disposable item, and it is in the operating rooms at multiple places where I operate because the ophthalmologists operate here as well. I'd hate to think what they do with this on the eye. But it's beveled, it's sharp, it's low profile, and it's very effective at releasing adhesions underneath the extensor tendon between the phalanx or in the flexor tenolysis as well. So if you don't have the capital budget to purchase these expensive tenolysis blades, look for alternative solutions like this ophthalmology crescent blade, which I find very helpful. Some pearls with regards to management of these injuries and circling everything back to what has been discussed by our other lecturers this morning. Intramedullary implants do have less extensor tendon irritation because they are within the bone and not sitting on top of the bone. But these have a very steep learning curve, and they can be very frustrating because of the size of these bones, particularly in more comminuted or unstable fracture patterns. Lateral plates, as Dr. Mezera showed us in some of her talks, or some of her cases, have less contact with the extensor tendon. You can excise a lateral band to allow for retraction of the extensor tendon in the other direction, and then leaving that plate on the lateral or dorsolateral side with minimal extensor tendon contact may result in less tendon adhesion formation and earlier range of motion. Obviously, with these more stable fixation, intramedullary and plate fixation, you want to get these patients moving very quickly. Closed reduction and percutaneous pinning with K-wires is a very common utilization of technique for phalanx fractures. And as the more gray hair I get, I tend to go more in this technique. If you have to open a fracture to reduce it, then you should give it some stability with more stable fixation. But if you can treat this fracture with closed reduction and a couple of weeks of K-wire fixation, they do okay. But it is important to make sure that you are mobilizing all of the joints that are appropriately mobilized. So if in this case, you can leave the PIP and the DIP joint free for range of motion and immobilize only the MP joint, they will be that happier and they will do better in the long run. But if you have to open or reduce these fractures, you want rigid fixation with early referral to occupational therapy for mobilization to avoid or minimize the potential for the need of extensor or flexor tenolysis in the future. Thank you very much.
Thank you so much, Dr. Malone. I think we got a few minutes to do a couple cases here. Let's see.
Evan, I have to say, when I was training, I had a mentor that it was basically a cardinal sin. If you opened a fracture and you didn't put stable fixation in it, you knew the Chiefs conference was going to be a really rough time when he started looking at your x-ray. So your point is well taken. I mean, and sometimes it just, sometimes you do have to put K-wires or something, but definitely if you open a fracture, try to fix it with stable fixation. Otherwise, it's kind of the worst of all worlds.
Desperate times certainly call for desperate measures, but yeah, I think you got to have your plan A through D as you discussed. And if your plan A involves opening the fracture, then do everything you can to provide rigid stability so you can mobilize those patients.
For sure.
There was an interesting question in the chat, and it was about the duration of K-wires. And I'm intrigued to know, because it sounds like Dr. Malone answered that question and said he leaves the K-wires for about 4 weeks. And Dr. Mezera, you were saying that, 2-3 weeks is sometimes all the longer.
I think 2 is probably, I would honestly say I probably would be a little bit ginger about removing them at 2 weeks. Mm-hmm. In a young person, like maybe a PD age group, I would do 3 weeks. Mm-hmm. In an adult or someone that's, more elderly, 4 weeks would probably be my comfort zone, honestly. But I was mentioning that the x-rays don't always tell you exactly where you're at with healing in the phalanx and even in metacarpals to a certain extent. But I feel like I go by the clinical tenderness. If I'm palpating the fracture at 4 weeks and the patient's like, yeah, no, that doesn't hurt at all, but yet I'm still seeing on the x-ray that it looks like there's not much callus, I'll trust the exam over the x-ray. Does that make sense? Yeah.
100%. Yeah, no,
I'll pull those K-wires.
Yeah, it's interesting. I think it depends on the patient population too, and how much mobilization they're doing. So if you're rigidly immobilizing them for a few weeks, you can probably pull those a little bit sooner. If you're starting some early motion or they're a little bit more mobile, then I tend to find that those are people that I'm leaving those K-wires closer to that 6-week mark. So if I'm starting early motion with OT, I will sometimes leave those deliberately till 6 weeks. But as you said, it's all about that. It's about the clinical scenario.
Yeah.
I think, a lot of it just goes into the degree of soft tissue injury, as I tried to write in that response. Open fractures, significant periosteal stripping, metabolically poor patient, smoker, those type of things. Those fractures are going to take longer to heal. And it is certainly better to have a stiff finger with a healed fracture with good alignment than a fracture that falls apart because you have pulled the implants out too fast.
We have an interesting question in the chat. We might answer live. Emil's on with us, and he's asking, how much should we try to get anatomic reduction versus a functional reduction before making the decision to open?
I think it's a great question. And I think it's a question that as somebody more junior in my practice, I think it's something that I constantly struggle with. Like, when is the x-ray good enough? And I try very hard to remember what our goals are. And you're thinking about the alignment of the digit. You're thinking about restoring that anatomy. We know we can't have any rotational deficit. So if there's a rotational problem, I'm going to open to get it right. If it's appropriately rotated, there's a little bit of a step off, but it's clinically not deviated. I will probably choose not to open that fracture rather than make that x-ray perfect.
Yeah. I mean, I would echo that. I think you have to, if you can't get your rotation or your scissoring fixed, and you have to open it. I mean, that's a, you're kind of dead in the water on that one. But if your articular surface is reduced, you have no malrotation, you have no angulation, and you feel like you can really get good stable fixation. If it's translated a millimeter or two, it doesn't bother me. If my x-ray isn't perfect, it doesn't bother me at this point. I would prefer to definitely take what I have that I'm happy with and not open the fracture site before I would open it just to get a perfect x-ray. I don't think that's worth it. 100%. I don't know if you have a comment, Kevin.
No, I agree. Rotation's critical. And when you're fixing these proximal phalanx fractures, which is the ones that we most commonly fix, by putting the patients into a fist and then inserting K-wires or your screws or whatever kind of controls the rotation as you're placing your implant. Patients will tolerate certainly a few degrees of coronal or sagittal plane angulation. Translation, I think, is very well tolerated as long as you have the other parameters pretty good. And so if you can get them into that fist and their fingers line up well, your rotation is good. Intramedullary fixation, minimally invasive fixation, percutaneous K-wires, I think all do very well.
Agreed. Yeah. There's some good questions in the chat, but I want to show at least a case. We'll try to get to one here. All right, so this is a 24-year-old right-handed construction worker, and he had these quote-unquote open injuries from a metal grinder. And so you can see he's got middle finger P1 transverse fracture, and a fracture not dissimilar than I think several of the fractures that Dr. Mezera was showing, where it's kind of that long spiral, almost like a butterfly fragment, but it's a spiral with extension, maybe not quite to the articular surface, but you'd have to really scrutinize those radiographs to know for sure if there was a significant articular component. And I'm curious, how would both of you approach these? What would be your treatment?
So, you want to go first, Kevin, or you care? Okay.
Go for it. I'm typing a response here.
Okay, gotcha. So if we start with that long finger, obviously we have what appears to be a pretty simple transverse fracture. There might be a little area that could key in there, which might help you with your reduction. Sometimes those completely straight across transverse fractures that toggle, they're a little bit harder. It's nice to have something to key in. So I think you could probably reduce that. I think an intramedullary fixation would be reasonable. I don't know how the soft tissue actually looks. I mean, maybe the soft tissue is worse than I'm thinking. So not terrible, not terrible. So in that case, I think you probably could do an IM. I mean, you could also do K-wires. I mean, if the soft tissue was bad, let's just say that you had a concern with putting, metal in permanently. I think K-wires would work good in this particular location for this fracture pattern. So I think that would be very reasonable. The index finger is obviously much more unstable, that fracture pattern. I mean, you have, basically looks like a large butterfly fragment in a way there. That fracture probably doesn't extend to the base of that proximal phalanx. So that's going to be a highly unstable pattern. The problem with, intramedullary is not going to help you. K-wires aren't really going to help you. I don't think they're able to control this fracture well. The plate, maybe, but you're so proximal that it might maybe be a little difficult to get your proximal plate fixation, but maybe you could use like a T-plate or a long T-plate or something. But I think lag screws potentially would offer some good fixation here. But I think it either has to be lag screws or a plate in my mind.
Yeah, I would just say that, you can't isolate or you cannot independently rehab these fingers from each other. So whatever your least stable fixation technique is going to be for multiple digit injuries is going to be that's going to control the rehab program for all fingers. And so, if one of those fingers is going to require K-wires, then you might as well try to K-wire all of them because you're really not going to be able to move them. But if you think you can open reduce these and internally fix them with stable fixation so that you can more quickly mobilize them, then you should do that for all digits. As Kim showed in her talk, lag screw fixation, we can do this in the hand with lag screw fixation only, whereas our trauma surgery partners look at this and say, how could you not neutralize that with a plate? So I think that index finger is asking for a couple lag screws from that butterfly fragments into the proximal and distal segment. But the short oblique or transverse fracture of the middle finger, you can't lag that. But that probably is pretty easy to reduce and put a little compression plate on the, dorsal lateral or dorsal ulnar or dorsal radial side. And so you can move this patient very quickly.
So for a closed fracture that's that short oblique, would you try to do a plate if you're planning on plating the index, or would you still try to go with the intramedullary? I mean, you said it's really about doing the rehab, but do you rehab those the same?
So I think you could rehab them the same. That my concern would be is that the fracture on the middle finger is right through the isthmus, of the middle finger, of that proximal phalanx. And so, if you're going to do a retrograde screw, as some of the cases that you showed, that screw is going to be floating around in that proximal segment, and you may not have as much control there as well. The Y pattern or using the two screws from the proximal segment, I struggle with. So I think if I was going to rigidly fix this, and I wanted to have more confidence in my ability to move these patients, I would make dorsal radial incisions on both fingers, excise the radial lateral band on both fingers, interfrag compression screws only on the index, and then a little lateral plate on the middle finger.
I think these are all really good points. And there was one other thing that Dr. Mezera said that I thought was really important. I don't know if we touched on earlier, was about the soft tissues and K-wires. So if you've got somebody with really horrible, trashed soft tissues, contaminated wounds, something like that, it's not a time when you necessarily want to put in permanent hardware. And so it's a time when almost always I'm K-wiring those patients. So at Harborview here, we make a lot of porcupine hands because we don't want to put permanent hardware in.
It's definitely a consideration.
So I did exactly what Dr. Malone said maybe you shouldn't do. And I did a retrograde intramedullary screw for this patient. There was, Dr. Mezera pointed out, there was that little key from that short oblique fracture. And so it was possible to kind of get that keyed in and get that reduction. I think it's a totally fair point about whether that's the appropriate implant for this. The one thing that is nice is you've got this straight implant going through a curved bone. So you get some component of a 3-point bend, especially if it's on the more dorsal side. And you think about the deforming forces on this finger, and it's going to be predominantly in that flexion extension plane. So you can argue it. In this case, we did this and we felt comfortable mobilizing him right away because I generally will move these patients quickly. And I do agree with you that that two-screw technique is very, very cute and very fussy to do. And then for the other fracture, we elected to open it because it's an unstable pattern, not something that you're going to get a reliable closed reduction and certainly not get closed fixation with K-wires. I start with K-wires, get the reduction in place, and then transition that to a small plate lateral, excise the lateral band so that there's nothing overlying it. Could we have done this with isolated lag screws? Potentially. I think that we were, because of the shape of that butterfly fragment at the base, we were fairly perpendicular, I felt, to that fracture with the position of the plate. And we actually positioned that plate slightly dorsal, which I don't know if you can see in these radiographs, in order to accommodate being relatively transverse. And so you were essentially lagging through the plate, although we placed it as a position screw, not a true lag screw. And then this patient at 5 months post-op was healing. You can see there's a little bit of delayed radiographic healing at part of that index finger proximal phalanx, but good robust healing at that short oblique fracture. And his motion was excellent. So I wish I had images, but I'm terrible at remembering to take those pictures of patients. But a really nice tight fist, full extension. He's returned to his job of injury and construction and has absolutely no limitations.
How soon did you move him, Chelsea?
Right away. My hand therapist like 3 to 5 days of soft
Okay.
tissue rest, and so I will splint everybody out of the OR for 3 to 5 days. I don't put them in just the soft wraps. I give
Yeah.
them soft tissue rest for 3 to 5 days, and they start hand therapy with supervised hand therapy.
Nice. Yeah. That's a nice outcome.
Yeah, sometimes you get lucky, right? We are at 6:06. Do you think we have time for one more? Or should we call it?
Sure.
One more.
One more.
We'll do one more. Okay, so this is a 21-year-old male. He's a basketball injury patient. He's one of those where you've got to look at it in extension and flexion, as Dr. Mezera said, because you can get fooled in one direction or the other. And this kid was adamant that his finger was just fine. But if you look at it just on these AP views, you can really see that there is some deviation of that digit. And if you can envision, as he flexed his hand down, his pinky finger pointed, off the ulnar border of his hand. So we indicated him for surgical fixation. And then this one, there might be just resounding agreement. Maybe it's too easy. How would everybody fix this?
Well, I mean, to me, it's almost begging for some lag screws. I mean, I do like lag screws. I think that would be, I think it's a long enough oblique that it would certainly be amenable to that. I think plating isn't the wrong answer either. But it might be a little overkill for, what you need to do. Now, I've actually seen, I don't know if I'm in agreement with it myself, but I've seen as the intramedullary fixation indications are maybe broadened, I've seen some of these oblique fractures treated with the IM fixation. The risk to me is that you compress and you're going to slide, it's like downhill slide. So I don't know exactly. I don't know if that's a good idea. I see it. I see people that have had surgery elsewhere that I'm thinking, well, that was kind of maybe stretching the indication for an IM nail, but they're doing it. But I don't think I would be comfortable with it. I think the fracture is too oblique for me, but I would probably go with lag screws.
If this patient comes in quickly and you can get him reduced close, this is a border finger. So he would tolerate K-wires on the ulnar aspect of the finger because it's not going to get interposed between the ring finger or any adjacent finger. I think if you can get this fracture reduced close, I'd probably just K-wire it. If I couldn't get it reduced close, I would open it and put lag screws in. But even if you put lag screws in, you're not going to let this guy go right back to basketball. You're going to wait for that fracture to be very well healed. So I think I would try to be less invasive in this situation if you could get him reduced appropriately.
Yeah, I love all those comments. It's I always try to reduce him close no matter what. And he was 21, but he behaved like a 13-year-old in terms of his healing. So he was solid as a rock at like 10 days out. So we did open him. And again, I like to provisionally reduce things with K-wires, especially here. And so we got him reduced. We're really happy. And then we did, in fact, Use a couple cute little screws, and because of the shape of this oblique, they're in a similar orientation, but you can see that deviation as you're staying perpendicular to the fracture line. And we're really pleased with the reduction we got in surgery. This is one that I still did allow him to move at about that 3 to 5 day mark because I felt good with my fixation. And again, the goal is sufficiently stable fixation so you can start these patients moving. And so I did let him move. He was not playing basketball, mind you, but he was moving.
Movement is different than going back to sport, particularly, football player, you put them in a lineman, linebacker, whatever, you put them in a cast and let them go play. But basketball is a different animal for sure.
I have just one comment, Chelsea, about the correcting a malrotated finger closed. Sometimes it goes really smoothly and you're like, wow, it just corrected, the cascade is restored. It looks great. Put a couple K-wires, and sometimes it can really challenge you, right? It's just really hard. There might be something interposed. Maybe there's some periosteum in your fracture site, maybe something. It just seems like you're really trying to get that cascade restored, but it's just not working and it stays malrotated. So I've had that situation both ways. So I think if you try to, you're trying to restore your cascade and you're working pretty hard at it, but the finger stays malrotated, I would bail and open it because there's something blocking you. And otherwise you're going to end up doing something that you're going to regret with the fracture, if you push it too much.
Yeah, there are times when you open them and you try to make a small, cute little incision, and then you still can't get them, right? Because there's still something.
Still something.
Yeah, if you've committed to open, it's gonna open. But it's one of those things. It's part of why they're humbling. You think you're being cute. You make a small little incision. You kind of try to open up that fracture, reducing, get your lags with a small exposure because you don't want that scar tissue. And you can be continuously reminded of why these are challenges.
Yeah, but I would say my advice is don't fight it too long. If you can't reduce it, if you can't correct the cascade just in the scissoring, just open it. Be done with it.
His motion was a little slower, this young man. So at 3 months, he's radiographically healed. I was really pleased with the healing. I told him at this point to go back to his basketball, gently, but his motion is still recovering, but he's making weekly improvements and actually letting him go sometimes and taking the reins off the motion for some certain patients is really the key to get that motion back.
Right. I think that's probably pretty good time to wrap it up.
I think that's a perfect time. Well, thank you both so much for being here, and thank you everyone for joining us. There is a recording, so I know at times specifically me was speaking a little fast, so please go back and review the recording. There's lots of good info on the slides that we didn't get a chance to share, so please enjoy that and look at the upcoming AO events.
Sounds great. Good night. Thanks.
You both.
Good night. Thanks, Chelsea, for including me. Thanks, Kim. Good job.
Yes.